We are live.
Thank you. So good evening, everyone. Welcome to the AIOS webinar titled Walk-in Patients with Irregular Astigmatism. It's how to investigate, manage, and triage. It is my proud privilege to be a program director, and I thank Dr. Hunawar sir for this opportunity. And I will be moderating this webinar, and along with me will be Dr. Purvasha Naran to moderate the same. We're excited to have this distinguished panel of speakers and chairpersons and panelists to this August gathering. I'll just share my screen to introduce them. So the chairpersons of this webinar is Dr. Samar Kumar Basak. He is president of AIOS and he is a senior most consultant at this eye hospital, Kolkata for cornea. Then we have Dr. Rohit Sethi, a doyen in this field from Narayana Nethralaya Eye Institute, Bangalore, and he is an authority on irregular astigmatism. Next, we have Dr. Krishna Prasad Asar. He is from MM Joshi Eye Hospital, Hosur, and he is very good with this topic. And next, we have Dr. Anamika from State GS MC and KEM Hospital, Mumbai. She is also a senior consultant for the same. Dr.
Good evening.
Purvasha.
Yeah, good evening, everyone. And I would like to thank Dr. Santosh Hunawar sir and Dr. Nilesh for letting me be part of this AIOS walk-in patient webinar. So the moderators for the day would be myself and Dr. Nilesh. He's a consultant at Madhavi Nethralaya, ARA. And of course, the man of the hour, Dr. Santosh Hunawar sir, the Honorary General Secretary of AIOS, who's also the head of Center for Sight, Hyderabad, along with Dr. Manoj Mathur sir, the Honorary Treasurer of AIOS and the Director of Swaroop Eye Center and Medivision, Hyderabad.
Next up, we have an extremely expert panel, starting with Dr. Jinu Priya Tyagi. She is at Lokpriya Hospital, Meerut, and Dr. Karishma Wadia from Jehan Eye Clinic, Mumbai. Next, we have Dr. Meena Lakshmipati ma'am, a senior consultant from Sankar Nethralaya, Chennai. Dr. Praveen Krishna V from LV Prasad Eye Institute, Hyderabad. Sir had some engagement and he couldn't make it at last moment. He had to back out and he is extremely missing this webinar. Next up, we have Dr. Shomshila Murthy ma'am. She is from Shantilal Sangvi Eye Institute, Mumbai, and she is member of Scientific Committee AIOS. And last but not the least, we have Dr. Vinay S. Pillai, a senior consultant of cornea from Girdhar Eye Institute, Ernakulam.
And we are also very lucky to be having with us presentations from Dr. Ananti. He's the consultant at Lotus Eye Hospital and Institute, Coimbatore, along with Dr. Ashik Khurana, who is the head at CL Gupta Eye Institute, Moradabad. Dr. Bhaskar Srinivasan from Code Eye Care, Chennai. Unfortunately, he also cannot be with us today. He'll be joining later, most probably. And Dr. John Sarkar from Shushrut Eye Foundation and Research Center, Kolkata. Dr. Manik Nicholson, Shantilal Sangvi Eye Institute, Mumbai, and Dr. Madhu Uduraju, Dr. Ramana Raju's Vision 3 Super Specialty Eye Care Center, Vishakhapatnam. We welcome you all.
So with this, we will start our webinar. And it is my extreme privilege actually to invite Dr. Anand sir. He is my thesis guide and whatever little I know about this topic is thanks to him. So sir is going to present his case on initial assessment and diagnosis of irregular astigmatism. Sir, over to you.
Thank you, Nilesh. So first of all, good evening, everyone, to all the panelists and the chair people and to the viewers. Is it visible now?
Yes.
Yes, sir.
Is it visible? Yeah. Yeah. So thank you, Nilesh, for this opportunity, brother. So look at my first slide. If the patient is walking in with a irregular astigmatism, typically he will come with this sort of complaints. There is some amount of blurred vision, there is distorted vision. He might complaining of ghost images. There could be small amount of polyopia, like multiple colors of this name. He can be having multiple prescriptions in his hand and multiple doctor visits. He'll be most of the times unhappy with his vision. So this is the first complaint of an irregular astigmatism patient. This is how he walks in. And how to define it? Again, the slide tells that the two principal meridians are not orthogonal. they do not maintain that 90 degrees to each other. This is how we are going to suspect the irregular astigmatism in a patient. The degree of visual loss will always depend upon how irregular and how the astigmatism is. This has to be kept on the mind. Next slide. Yes, next slide. Yeah. What happens to this irregular astigmatism once it starts? It can take up a different form. There is no paper as such globally or at our national level that what's the fate of this irregular astigmatism. But in my OPD, every day I routinely do around 15 to 18 topos. 95 to 95% of the times, these irregular astigmatism, they land up to become a keratoconus. Rest of the reasons what I have mentioned is also a manifestation of this irregular astigmatism, but they are quite rare in my practice, but most of the times they do become keratoconus. As I mentioned, we need to suspect and think of the irregular astigmatism in its first place when it comes with the typical complaints which I told in the first. And once we start examining, there will be loss of PCV. It doesn't improve to 6/6. Whatever the corrections you do, and there will be fluctuating vision. The moment you try to do the improvement with the pinhole, it doesn't improve with the pinhole. We need to rule out rest of the opacities or the macular causes, which doesn't also improve with pinhole. Again, review all his records, prescription, and listen to the patient. He is giving us a clue that he is a patient of irregular astigmatism. The most important thing is the refraction or the retinoscopy. What happens, the cornea, whenever irregular astigmatism develops, it will be slightly myopic in comparison to the periphery. So whenever the glow we do with the retinoscopy, there will be against motion in the center with the motion in the periphery. It is just like opening up of the scissor. So that's why we call it a scissor reflex. In my practice, I would notice that even a preclinical keratoconus or irregular astigmatism patients, as soon as they're becoming topographic positive, scissor reflex, a smart optometrist can pick up. So even a ophthalmologist who doesn't have access to the topographies with a smart detection of scissor reflex, you'll be able to detect the irregular astigmatism. Once the irregular astigmatism starts, it brings about the changes in the cornea in terms of asymmetry. It brings about the elevation changes. They can be followed by the thickness changes. So whatever the indices we derive or we routinely use are based upon only three factors, which is asymmetry, elevation, and the thickness factors. If you look into this topography, which is from Pentacam, you can see the skewing, you can see the bending, the axis, they are not orthogonal. There are significant elevation changes. The artificial intelligence of topographies gives us the data telling that if they fall into the red category, it is telling that it could be a case of irregular astigmatism going towards the keratoconus. We need to be aware of all the positive elevation values, whether on the anterior or the posterior elevation maps, which gives us a clue even in a case of preclinical keratoconus, such as form first or subclinical keratoconus or keratoconus suspect patients. And there are so many indices which works on the principle of asymmetry on the data of the elevation data which are present on the asymmetry will always gives us the clue towards the diagnosis of irregular astigmatism progressing towards keratoconus. The thickness index, which was initially derived from the OPSCAN, the principle of all this remains the same. The difference of the pachymetry when compared from periphery to the center should not exceed 100. If it start exceeding 100, when you divide all the peripheral thickness ratio by the central ratio, you start getting this corneal thickness spatial profile or percentage thickness index to be very, very significant, and the Pentacam values or the artificial intelligence will keep putting this data in the red color, thinking that it could be a case of irregular astigmatism progressing towards the keratoconus. Cirrus is also one of the topographies which we use. If we look into this topography, Cirrus values, on the left-hand side, I have my own eyes topography, and on the right side, you have a patient with early irregular astigmatism comes up. Here, we use the values such as symmetry index of the front side, keratoconus vertex of the front and the wing. There is index called as BC because it's an Italian machine. All these words are from the Italian. The normal words are mentioned. As soon as the irregular astigmatism start projecting in terms of asymmetry and elevation, you get all the details getting altered. This gives us a clue for the diagnosis. And the most important thing we need to understand is there will be significant changes in the wavefront technology as soon as the irregular astigmatism starts. So the equative data of all the aberrations, such as third order aberrations, coma, they get altered. They become significantly higher whenever the irregular astigmatism gets started in any cornea. You just compare these values of I don't have a pointer, so the coma values, the spherical aberration values, and the astigmatism values, which becomes very significantly when compared to the early irregular astigmatism to the next slide where the irregular astigmatism has not started. There's a significant difference. You start getting this coma kind of thing back in the keratoconus or early oblique astigmatism patient, and which remains within normal limits. So to diagnosis, the most important thing is the loss of BCVA, the scissor reflex, no improvement with the pinhole, few indices which can pick up, and alterations in the wavefront values. Thank you.
Thank you so much, sir. That was a very succinct presentation. And I still remember the pulse that you gave me in OPD when I was working with you. And today also one patient similarly walked in 612 vision not improving. Like BCVA was 612 and not improving and high cylinder, and immediately I suspected keratoconus and it turned out to be so. So thank you for those pearls. Let's start with discussion, sir, and please pitch in whenever you also want to. I'll start with Dr. Jinupriya, ma'am. Ma'am, what clinical sign, apart from this loss of BCVA, should alert the clinician to suspect an irregular astigmatism if the person is not having a good optometrist who is picking up the scissoring reflex? Ma'am, you're on mute.
Thank you for the question. So we should always ask about the history of the patient. If the patient is having repeatedly his number is increasing, or if his cylindrical number especially is increasing, if there is history of eye rubbing, or you can ask about their sleeping positions also. If they like in any way they press their eye, like while sleeping, they can press their eye like this, or either they're rubbing. So that gives a clue that there may be some problem. And then family history also you should ask. And you should along with all these things, if along with the history and the clinical sign and symptoms, and then you should ask for the pentacam, and then you should go about the diagnosis.
Thank you, ma'am. And to Vinay sir, a follow-up question about the same. Sir, what is your experience about the incidence of this irregular astigmatism in patients with chronic condition like VKC, blepharitis, allergic conjunctivitis as such?
Yeah. So that is one very important thing. Irregular astigmatism doesn't always mean it is keratoconus. Okay. It means there is an irregularity on the surface of the cornea. Right. That is one thing. The second thing is all reflexes which are, retinoscopy reflexes, which is north, may not be classic scissoring, but then irregular reflex again doesn't mean it is keratoconus. Okay. It is an irregular surface, or there is a media opacity somewhere, okay, causing this opacity. So that has to be differentiated, right? So, coming back to your question, VKC association with keratoconus is there, and Meibomian gland disease and VKC can cause surface changes. Okay, there can be a lot of irregular surface epithelial problems, corneal scarring. Okay, all these can cause irregular astigmatism. Okay, the final net effect is what has been discussed till now: patient not improving with spectacles. Okay, that is the most important sign of an irregular astigmatism.
Thank you, sir. Thank you so much. Anand sir, any parting thought before we move on to next talk? Okay, thank you, sir. So next up, Dr. Purvasha.
Yeah, so we move on to our second presentation now. I kindly invite Dr. John Sarkar, a dear friend, to please present on differential diagnosis and different causes of irregular astigmatism. Over to you, Dr. John.
Thank you, Dr. Prabhasha, for your kind words. I'm sharing my slides. Am I visible?
Yes, these
Am I audible?
Yes.
Yeah, thank you very much. And along the last continuation of the talks of irregular astigmatism, I'm just starting this little complicated, weird picture. So it looked like very difficult for all of us. But as soon as I put these things, it's very much clinical, irrelevant that we know these things, what happened, what the patient complained. This is a normal vision, this is the, and this is what happened with these things. So exactly what is the problem and what are the causes of bends like thinking. So without wasting much more time, I'm just going to my own topic, that different causes of irregular astigmatism, or what are the degree of the irregular astigmatism. I have no financial interest. So already my previous speaker and give the definition what exactly astigmatism. Very simply, according to the American Academy, astigmatism is a common vision condition that occur when the cornea or the lens of the eye is irregular shape and common refractive error, and that causes the refractive error. But the refraction changes in different meridian of the eyes. The light passing through the eye cannot converge in a particular focal point, but form a focal line according to the, and it's approximately common. It's 13% of the refractive error in human eyes. So what is irregular astigmatism? It is fairly uncommon, clinically relevant. Irregular astigmatism produces a curvature at each meridian that is not uniform. So what are the causes of the irregular astigmatism? It can be innate. That innate astigmatism is usually due to congenital corneal pathology that can be either stable or the progressive, or it may be acquired. The acquired astigmatism is more commonly secondary scarring or ectasia. What the causes of the acquired are corneal ectasia, most common the keratoconus, which is already explained by previous speaker, keratoglobus, pellucid marginal degeneration, anterior degeneration. Other two conditions are Salzmann nodal degeneration or pterygium, corneal scarring post-infective, mostly post-HSV or the PUK, or the even also post-Moran, or it may be the surgical trauma like post-PK with multiple sutures, post-RK radial keratotomy, or post-LASIK ectasia. So I'm just sharing my slides with some of the relevant case based. Thus, it's very common in our OPD, but sometimes we missed. So what the algorithm we follow as in our cornea OPD, I'm just following this thing very simply. So I'm just showing the pictures of the patient who having this young adult myopic with the high cylinder power, with history of allergic conjunctivitis or vacancy and frequent change in glass power. So on clinical examination, while finding these things, we have to proactively search for whether there is a Fleischer ring is there or not, or a Voxtra, either of the eye, and we make the slit beams and find it out whether the having this patient have the ectasia clinically present or not. Secondly, we'll do the cyclopic refraction and look for the scissoring reflex, which has been very clearly explained by previous speaker. And we have, whenever we have suspect, always when a patient having the vacancy with the high cylinder, it's better to diagnose the thing rather than underdiagnosed or undiagnosed. So we usually routinely send the patient for OP scan or pentacam for tomographic assessment. But three things we should very in busy OPD, we should not be missed. One thing is that what is the K reading of the patient? If the K reading any relevant is more than 48 diopter, or what will be the thinnest package of that respective point? If it is thinnest package less than 500 or 450, or what will be the posterior elevation? It may be differ in the OBSCAN and pentacam. If it is a OBSCAN, if the posterior elevation value is more than 57 micron, or if it is between the 25 to 30 micron more than that in the pentacam, always this should be suspected. Maybe I'm dealing with the keratoconus, and we have to be proactively look for that and regularly follow up the patient for progression and respective treatment. I'm not going in details of that. I'm sharing my second case is an adult myopic with a high cylinder with history of irregular astigmatism. And you can see this thing, this patient having the curvature has when you make a slit beams, curvature is different. And when you do the OB scan, we found this is the topograph, this is the K reading or keratometry reading. Very classically, we got this finding, and this bell shape finding in case of where we'll do the in case of topographic one, pachymetry. And there is a pachy progression map showing the upward I mean, drowning. So it is not parallel with the, the second normal pattern of the refractive error or the keratoconus. So probably I'm dealing with the pellucid marginal degeneration. So it should be keep in mind it whenever the patient comes, it is not always the keratoconus. Maybe the combined PMD with the KC can be present. I'm dealing with third cases with the myopia of the high cylinder, with history of frequent changes in the glass power, with irregular astigmatism and not comfortable or contact lens, and there is a fitting and the problem. And when you do the slit limb, this is very obvious. The curve is very huge curvature from one limbus to another limbus, and probably I'm dealing with the case of a keratoglobus. If you do the keratometry reading, you can see there is a huge, almost enter whole cornea from one limbus to another limbus is involved, and the pachymetry as well as the in case of your keratometric maps. I'm just showing my fourth cases where young adult with a history of conjunctival mass with a progressive cylinder. Sometimes maybe the pterygium can be present, or the trauma which can cause the vascularization that can causes the looks like pterygium, but it may be the pseudopterygia, and that causes the irregular astigmatism. So this patient having this, you can see there is another progressive nurse, and it patient is there is irregular astigmatism, not comfortable with the glasses. So and when I do the topography and the K reading showing there is almost 40, you can see this 45, 46, the steeper K. We do the cyclopathy refraction along with the PMT, and definitely for this patient we do the, excuse me, my slides, we do the scan of the post-op, we remove the surgical excision of this thing, and this is almost, you can see this patient, and this is almost, 3 weeks, 4 week post-op, and this drastic is significantly 5 diopter reduction of the K reading. So probably it can be keep in mind that it is not always the normal cause. Some of the causes very common frequently, and it is not a relief. The patient not amenable by the glass prescription. You keep in mind that you have to give the respective treatment of that patient. Should not be miss the diagnosis. I'm dealing with my next case is the middle-aged with a high cylinder with irregular astigmatism, no history of trauma. And this is what pretty common in this middle-aged patient, male or female patient. There is a superiorly, there is a arcade, there's a dense arcus like things are there. Sometimes the patient having the mild stromal granular infiltration could like things are there and had a history of the maybe scleritis, may be present or may not be. And we have to allow and patient are most of the time the your colon vascular disease are negative. They have this type of peripheral vascularization and there's a congestive pterygia formation. This is probably is this type of patient is present with you. Do the refraction, but they are not comfortable with the glasses. They are not comfortable with your these things. The simply the contact lens too also. So probably maybe you are dealing with the, excuse me, the slides. Yeah. So probably I'm the terrain degeneration, and this is actually this is my that topography one actually is shared by my one of my friend. It's not my patient one. I'm dealing with another irregular astigmatism, pretty common in our general OPD as well as the cornea OPD. Young adult myope with a high cylinder power who had a history of trauma. This patient came to us long back during the time of COVID with a bad very sclerocorneal injury. He had actually we had done the patient first sitting, this is called a repair, and the lens was there is a breach in anterior lens capsule. We do the anterior lensectomy with the vitrectomy, and after 2 months after removing all the suture, we have done the patient's that is the lensectomy and vitrectomy followed by CTR and the 1/3 piece IOL placement. But the thing is that patient having a 6/18 vision, but there is a irregular astigmatism. He is not very happy and photophobic. So we have done this thing, the central visual part is clear. That's why we're not planning for the PK for this patient. So these are the post-traumatic irregular astigmatism for that patient option showing. And when you do this patient, this is but the patient very keen for visual rehabilitation. So simply you have done the minuscular trial and the vision is improved to 6/9. And he is very happy with this condition now. I'm just dealing with the last but not the least condition. That is another the young kids with history of the DALK. This patient had a history of the injury. Then we have repaired the cornea. Every superficial mid-stromal scar was there. So we have done this patient for the DALK 2 years back. But he's from the Tripura out of outskirt of the, they had difficult to come and locally he had a suture related infiltration. That time he could not come. When he came to us, he has this type of scar followed by irregular astigmatism and is extremely photophobic, stopped going to school. We do the cyclopathy refraction and rule out the scissoring and everything, but he is the photochromatic glass given, but he is not, comfortable at all. Then this is the post their OPSCAN report. Same this patient we have rehabilitated with the minuscule lens, and as of now, because they are not willing for any further surgery, but with this they have developed the vision 6:9 partial as maintained his school for last almost more than 6 month follow-up. This is the last cases post refractive. This is very pretty commonly seen in the cornea OPD. The post RK mark. This is very difficult sometimes to. If it is not cataract, if it is cataract, fair enough, you can do the cataract surgery, do the visual rehabilitation. But if it is not cataract, but patient is very keen for the visual rehabilitation, this type of patients, they are not at all tolerable by the your glass. Then usually what we will do, cyclopathy refraction followed by this patient. This is the picture. You can see with a high hyperopic shift and flattening of the stipper K, almost 38 and the 26 in the OS. And we have done this patient for a minuscule lens, and patient is doing well. So these are the very shortly I am giving the how to approach the patient. Whenever you have this type of things, always keep in mind that it is not only the keratoconus. So many things we are dealing with day-to-day practice, which could be the probable causes of the irregular astigmatism. This is the relevant study. Please go through it. One of the relevant study by AIOS in the Journal of Ophthalmology and American Academy of Medicine 2024. And this handling the irregular astigmatism very precisely written for within 2 pages. Please go through it. So these are the outcome of those things. So before finishing my talk, I just do think why should we know the differential causes? So then we can implement our knowledge to how to approach. First, want to determine the etiology and then figure it out. It is stable or progressing. If it is stable, you can treat it. But if it is progressing, such as form of the ectasia, you must first stop the progression. Thank you very much. Thanks for your patient sharing.
Thank you so much, Dr. Sarkar, for your detailed presentation and beautifully illustrated cases. We now direct our panel discussion to Dr. Karishma and Dr. Meena here. Dr. Karishma, we'd like to know what are the most common masqueraders of irregular astigmatism in your practice, and how do you differentiate between them?
So I think one of the most important factors which would contribute to this would be a stable tear film. Very often you have dry eyes, which will, the consultant is sitting in a separate cabin, and the topography is being done by a technician who goes in, does the topography and gives you a printout in your hand. And you may be misguided by the printout if you have not exactly examined the patient prior, because if that tear film is dry, it's going to completely distort and warp your cornea topography. So I think that's very important. Also, sometimes the patient has already worn a contact lens and come in, which is again warping your topography and can lead to a confounding factor. So it's very important, I feel, that you first examine your patient and then look at the topography. Another common mistake that is performed is in certain places they do the topography and they note down the K values and submit the K values to the consultant. So those people may not have actually seen the image of the topography. Again, it is important that you see the image before you just draw your conclusion. So you need to see the patient clinically, you need to see the topographic image, and then you look at the K values, not just any one of them.
Thank you for sharing your
Dr.
pertinent.
Subhasha, can I add something?
Yes, please. Go ahead, Dr. Sarkar.
I just 100% agree with Dr. Karishma. One thing is that what we follow actually in our practice, that whenever you are dealing with most of the time cornea as well as general OPD you are doing, so what we instruct our optometrist or junior consultant or fellows also, first not to dilate, or you don't do any, the Sharma or stain the thing, because it will that will change the interpretation of your finding. First,
Correct.
you see whatever you're finding, draw the finding, everything, and don't touch the cornea, don't do the AT, don't do these things. Then you will get the exactly whatever the interpretation of your OPSCAN or pentacam or your the other relevant test. Because if someone touches the cornea, then definitely the finding may be altered. You may have to wait for another day. Sometimes it pretty happen. It's very commonly happening. They direct the BR consult, direct the patient to us and ask for the refractive workup or the rule out the case. Then that day actually simply do the retinoscope and scissoring, ask the patient to come in that day. So that is the actual thing. If this simply thing we can implement in our day-to-day practice, it is easy for patient in this busy schedule for and the consultant too also. Thank you.
That's so true. Dr. Meena, we would like to know from you what are the various etiologies that you face in your day-to-day practice and how do you deal with them as far as the investigations are concerned?
So I think directly going for investigations is not the right thing. It sort of really scares the patients when you subject the child to a pentacam. One of the things that I learned very early on in my career is not to do investigation, not to do a printout and give a pentacam or a topography to a patient's parents, who forever carry the topography thinking that the child has a progressive corneal disease. So the first most important thing is a good retinoscopy. You will have to know if it's an irregular astigmatism, oblique astigmatism, or a bioblique astigmatism. And very often, yes, you can be dealing with a case of an amblyopic child. You have to rule out microtropia and amblyopia in these cases. And then look for any clear signs of nebular opacity in the visual axis, which is actually obstructing the vision. And of course, then you have, only then you will know that whether your vision, your retinoscopy, and your cornea are all coinciding. The red flags are very easy to find. The ectatic corneal diseases, the corneal dystrophies, the injuries to the cornea are all probably very easily visible. One of the causes of irregular astigmatism, if a patient has been recently been symptomatic, is if he has a epithelial basement membrane dystrophy, where there will be disturbance in the basement membrane and epithelium can be irregular. So these are some of the things, and I always caution patients who have flectinular keratoconjunctivitis to be very, very careful, because these children with flectinular keratoconjunctivitis, unlike adults who present with marginal keratitis, tend to have a vessel or a fascicular based ulcer proceeding to the center, and this can cause an irregular astigmatism. So leaving apart keratoconus, yeah, these are some of the cases that these cases that I've seen as irregular astigmatism.
Right.
Does that answer your question?
Yes, it does. Yes. So you've rightly pointed out towards recurrent corneal erosions and other pathologies or Salzmann's also that can present.
Yeah.
Right. So in our daily practices. Right. So we move on to the next presentation. Dr. Nilesh.
Yeah, thank you. And the next presentation will be from Dr. Ashikurana ma'am. She is going to present on navigating the curve, strategies for managing the irregular astigmatism. Ma'am, the floor is all yours. You are on mute, ma'am. Not yet. Someone from support, can you please send an unmute request?
Yes, doctor.
Yeah, so is it visible? Not yet.
Doctor, you need to share it,
No.
the green button on the Zoom.
Just 1 second, please. Okay.
All
Ma'am, you are on mute again.
Am I audible now?
Yeah, ma'am.
you are audible, doctor. Yeah.
Screen is
Thank you.
visible.
Okay, so I'll be talking on the strategies for managing irregular astigmatism, the financial interests. So I'll be first sharing a case like Nilesh had told me. So the first was, my case was a 27-year-old female police officer. She came to me when she had undergone a C3R elsewhere 18 months back for keratoconus, and she was advised to go for ICL. She came for refractive surgery opinion, and when she presented to me, she had a refractive error of 3.5 diopter cylinder with 2.5 diopter cylinder in one eye and 2.5 diopter cylinder and 2.5 diopter cylinder, both oblique. both the eyes, and she was wearing the same glasses, and she said that her refraction has been stable since surgery. And when I saw her, she had a keratoconus. On the demarcation line was not visible because it was an old surgery, but fundus both eyes was normal. And the keratoconus was visible on the topography map also. She had a good AC depth, and it was there in both the eyes, and you could see the irregular astigmatism on the topo maps. So since I was talking about the options, so straight away we'll talk about what are the options, treatment options that the patient could be offered for her refractive correction. So right now we're not talking about treatment options for other conditions like Pingicula or Salzmann. We're talking about this case. So the non-surgical options that are available first is the contact lenses. So while soft-toric contact lenses are not supposed to be very useful, but we do have an option of Kerasoft lenses, which are thicker lenses with a higher water content. Then you have hybrid lenses and piggyback lenses, which sit on the cornea, but because of rotation, there is a poor quality of vision. The other better options or preferred lenses in irregular astigmatism are the RGP lenses or the Rose-K lenses, which give excellent quality of vision. Or still better would be to go for mini scleral, which are tolerated better. And if the patient can afford, and insertion and removal is not a problem, the best is to go for scleral lens. So we offered these lenses to our patient, but this patient was very adamant that she did not want to go for contact lenses at all. So we have a good contact lens unit, but because she was not ready for that and she was only looking for surgical options, we would like to enumerate all the surgical options that are there for irregular astigmatism. So first being collagen cross-linking. Of course, not suitable for this patient because she was already cross-linked, but it is an option for patients which have progressive irregular progressive causes like keratoconus, pellucid marginal degeneration, Terriens, or post-LASIK ectasia. So there are multiple options there: epi-on, epi-off, President protocol, accelerated protocol, customized, off-center protocols for off-center diseases like pellucid or Terriens. The other option would have been to go for Intacs. Intacs are for regularizing the cone, and they create an arc shortening effect and flatten the reference axis. And although the results are usually very good, and we have about 3 diopter flattening, and there's a dislocation of apex to the center, but it does not work in previously cross-linked corneas. Other option would have been CARES. CARES are actually better biocompatible, and there are lesser chances of complications like MELS exposure, migration, extrusion. And they also cause more corneal flattening because of the thicker segments. But they also do not work well in a previously cross-linked cornea. The best option in any case of irregular cornea, which is looking for a surgical option, is to go for a topo-guided PRK. Now, topo-guided PRK is better than wafer-guided because it is repeatable, and it corrects the central cone location the best. And it doesn't operate too much, so it is up to 50 microns of only. But the thinnest Paki that is required is 450. So this was not an option for our patient. Another option that could be looked at is the pinhole pupilloplasty. Now, pinhole pupilloplasty is something in which was used earlier for symptomatic iris defects like colobomas. And this was used by Amar Agarwal, and they reduce the pupil size so that peripheral irregular rays are cut off. So the patient has more depth of focus, but the problem is that there is a reduced field of vision. So you can give a trial of pilocarpine before. If it is well tolerated, you can have different types of pupilloplasties like single pass, fourth row, Sipsers, bacchanal, circlet. So many methods are already described in literature. And similarly, you also have an option of a pinhole IOL, which is recently approved also, and people have been using. It is mostly used as a multifocal because it offers a greater depth of focus, but there's a very big problem that it is a reduced peripheral field, and also it reduces the light entering the eye. There's no financial interest. Then is there any role of toric IOLs or ICLs at all? Now, there is a lot of problem with toric IOL and ICL because the biometry is very difficult in cases of irregular astigmatism for the irregular corneas, especially post-RK and anterior basement membrane dystrophies and severe dry eye patients. And so in these cases, we have to use multiple modes of iris for access calculation. And most unpredictable outcomes that I feel in my practice are post-RK, more than 8 incision post-RK patients. We have to avoid patients with decentered apex, patients with skewing, and significant superior-inferior asymmetry. And post-PK patients also, I would avoid toric IOLs or toric ICLs because in case they may be requiring resurgery later. However, in my case, I plan to go for a toric ICL only. And we did uneventful surgery was done, and both the eyes were operated at a gap of 1 week. Post-operative walls were good, and post-operatively, the patient was doing well. She had pretty good vision. But after some time, she came back very unhappy, and she had a regression of 2.5 cylinder in both the eyes. So what we found was that her keratoconus had progressed. So although the patient had given a history that she had a stable refraction about 18 weeks back, and we found also that the refraction is stable, but we did not observe that whether the refraction is stable or not, actually. So my conclusion is always look for stability of refraction before treating irregular astigmatism surgically. Second is customize the treatment as per the cause of irregular astigmatism. And scleral or RGP lenses and topoguided PRK, in my opinion, is the best therapy. And we should under-promise and over-deliver. Thank you.
Thank you so much, Dr. Ashi, for your practical insights into the topic. May I now request Dr. Vinay Pillai to please answer a few questions for the panel. What factors influence your choice of planning for the management of irregular astigmatism?
One of the most important factor I would consider is the degree of irregularity on the surface. All these modalities, refractive modalities like ICLs or phakic IOLs, toric IOLs, they do well if the astigmatism is fairly regular, especially in keratoconus. That is one of the most important criteria. Then, if the surface is quite significantly irregular, the primary treatment aim will be to regularize the surface first, and then to decide on the refractive correction if required. Okay, now to regularize, there are a lot of options which Dr. Ashi mentioned. Okay, I mean, C3A per se doesn't help in regularizing this condition, but then combined with the topo-guided PRK in very selected cases, yes, it does wonders. Okay, the repeatability of the tests, the thickness, all these point towards whether are we going to get a good outcome in doing a ablation procedure to regularize the cornea. Or probably we may have to think about multiple procedures, like I have to have an intact or a KS first to partially regularize, and then correct the rest of with the surface ablation, topo-guided PRK. And then finally, once the surface is regular enough, I mean, one easy way to know whether the surface is regular enough is to do a basic refraction and see how much the vision improves with spectacles. Okay, if you're getting a good refractive correction with spectacles, then we know the surface is reasonably regular enough, and that is one place where we can think about thinking of a phakic lens or something of that sort for vision. If none of this work, the only option will be a RGP or one of the hard lenses.
That's so true. Thank you, Dr. Pillai. Dr. Anamika, how much importance do you give to establishing whether this is stable or progressive kind of an irregular astigmatism? How much time lapse would you like to allow before you start managing such cases?
Yeah, but I would like to know that because my patient, it was 18 months. She had a stable refraction, so I don't know what I did wrong.
You need to unmute yourself, ma'am.
Madam, and definitely I believe we should look for progression. However, having said that, we in children, which where we have to keep our pressure little low, we can be little aggressive in the treatment. But for the adults, definitely we will, otherwise we would get such surprises. I believe in looking for the progression.
Right. And
If I may add a point,
yes, please. Please go ahead.
I don't think there is a definite, time frame or criteria which we can say here. In terms of, knowing whether it is stable keratoconus, especially after C3R. I believe each one of us will have our own, criteria to follow. So whether you have done it early, I don't think so. No, none of us, I mean, nobody can say, that this is the time frame to say, yes, it is stable. Okay.
So what I suspected in my case was that she was a 27-year-old police officer. She's been postponing her pregnancy, and she's probably taking some hormonal treatment, and which she was hiding from us when we asked her for, when we were screening for surgery. So that is also one possibility. So maybe others can give feedback about how they screen their patients for stability of refraction.
I would like to add on that, sir. Can we have a time frame at what interval we should follow up these patients, Vinay sir? Every 3 months, 6 months, or?
See, I generally, see them after a month of my C3R to do the basic workup and then, give the refractive correction in terms of either glasses or contacts. Then the next is around 6 months and 1 year. Okay, and once in a year, if everything is okay, I just call them up, probably yearly follow-up, unless there is some other risk factors like uncontrolled allergy or something.
Okay, perfect, sir. That I think that is a very good take-home message that we should take.
May I
We
ask
should.
Vinay sir?
Yes, sir, please.
Sir, what is the
Before-
consideration for PRK-CXL, sir?
Sorry, I didn't get the question.
For
Am I audible,
PRK, CXL is
PRK-CXL, sir.
Can you repeat the question once more? PRK?
Yeah. Sir, what is your consideration for the PRK-CXL, sir? When the patient suppose high cylinder having the pack is thinnest pack is good pack. I mean, what the ma'am was, that Arshi was telling, the
It's talking
450,
about
what the ma'am
PRK,
consideration.
PG,
So what will be
PRK.
your consideration, ma'am?
When will I do topo-guided PRK?
Yes.
Best spectacle correction, any case where the best spectacle correction is 6/9 or less can be considered for PRK, topo-guided PRK. I don't do if the spectacle correction is 6/6 or the patient is happy with the spectacle vision which he has. If it is not, then they can be considered for topo-guided PRK with cross-linking, provided there is enough stroma to do the ablation.
Thank you, sir. We will move on to next.
Can I
Yeah,
ask
ma'am,
a
please,
question?
please.
Going back to Nilesh's question, Vinay, like I make a practice that whenever the patient, especially young women, to call them whenever they're planning a family or there is they get married, so that cross-linked corneas, they may progress because of hormonal changes at that time. So you.
Good question. See, I generally tell them, there is a possibility of it worsening during pregnancy and, immediate post-pregnancy because of hormonal changes. Yes, screening is there. Is C3R really protective of the worsening during pregnancy? There is no evidence, I believe. So this is what I tell them.
Thank you, sir. So thank you for all the comments and thank you, Ashi ma'am, for that wonderful presentation. And next we will invite Dr. Madhu Uduraju, sir. Sir is going to talk about his case-based approach on triaging strategies in walk-in settings. And that is a difficult topic to cover. Sir, over to you.
Thank you, Nilesh, for giving me this opportunity. And I also thank Jinupriya ma'am for making me part of this wonderful program. And it's a honor to be presenting in front of Meena ma'am, who have played a key role in my formative years of ophthalmology. So I'll now start sharing my presentation. I hope is it visible?
Yes, it's visible.
Okay. Right. So irregular astigmatism and the triaging strategies in walk-in settings. This is what the topic I was given. So the scope of this talk would be under the following headings: the background and what are the 3 scenarios that you can encounter these
Sir,
patients.
we are not able to see the full screen. Sir, can you make the full screen?
Slideshow mode.
Is it visible now?
Just went off, sir.
Well, I
I
think,
think, sir, you need to stop and reshare.
and I'll do it again. Yeah. Is it visible now?
Yes, sir.
Yes.
Thank you so much. Perfect, sir.
Okay. Right. So the scope of this talk would be under the following headings: a brief background and what are the 3 scenarios in which you can see irregular astigmatism in your OPD. That's a child, a young adult, and an elderly patient. And we'll conclude with a take-home message. So irregular astigmatism, that is something that you don't see very commonly, but it is very important that it should not be missed and it should not be mismanaged, because it does directly have an impact on the visual outcomes in these patients. And as most of the previous speakers have highlighted, the standard glasses and contact lenses, the regular contact lenses, may be of a minimal use in these cases, and the patients not be very happy with these corrections. And as Vinay sir has rightly pointed out, the degree of vision loss is directly proportional to the corneal surface irregularity and also the power of astigmatism that the patient has. So now coming to the 3 scenarios. One is child who approaches the clinic for glasses. Second is a young adult who wants a refractive surgery. And third is an elderly wanting a cataract surgery. So I think I'll keep it simple in terms of a general practitioner's perspective. So whenever a child comes and first time, whether it is the first time we are giving glasses or previously he is using glasses, so there are some telltale signs, that is frequent change of glasses, or the child is not happy with the glasses he is using, and the vision is not getting corrected to 6/6. So in our OPD, usually any astigmatism more than 1 diopter, we try to screen all these children under topography or tomography, whichever is available to you. If you only have an anterior topographer, you make sure you use an ultrasonic pachymeter also to look at the thickness of these corneas. And in these findings, what you see the most striking feature is the skewed bow tie and thinning. When you see a topography in such a kind, that is where you have to suspect ectasia, and being a child, this patient is likely to progress in this condition. So you have to very closely follow up these cases. And also you need not always depend upon only your investigations. If you listen carefully, the patients also complain of the quality of vision. So in our experience, what we see is they tell that the image is distorted. For example, they see a light, there can be a ghosting, or there can be a streak of light that is attached to the light that is already seen. So there are some classical things that patient tell that you should not miss when you're screening irregular astigmatism. And in these cases, I think close follow-up is very important, because you want to document progression in these cases. And as been already known, the most common cause for ectasias in these children are allergic conjunctivitis. So patient education about not rubbing eyes and all this goes into part of the education process. But once you have documented progression, I think it is more important to stabilize it with a cross-linking at the correct time. I think you need not document progression if the patient is in the teens or if the pachymetry is borderline. I think these are 2 conditions where you can skip off documenting progression and directly go ahead with a cross-linking. And also, contact lens correction may not be possible in children, but as they grow in age and when they're responsible enough to maintain their contact lenses, I think the contact lens vision has a better quality when compared to spectacle corrected vision in these cases of irregular astigmatism. So that is about the child scenario. Next is the young adult. I think already Ashi ma'am has covered this very well. So I think this is this young adult who wants to do a refractive surgery. I think in topography, when we pick up this astigmatism that is irregular, LASIK is out of question. And as they have rightly pointed out, if you have a good thickness, topo-guided surface ablation would be a good option. And if the candidate is not suitable for a topo-guided surface ablation, then my choice would be a phakic IOL. So we have done a few cases of phakic IOLs in keratoconus cases that are stable, and some of them do really well. But as ma'am has rightly pointed out, if there is a progression, that is something you have to deal with. But however, you have to educate the patient that you're dealing with something that is not very predictable. So the outcomes are also we need not be like a regular case. So that is what you need to educate these patients. I think in a young adult, I think the age is the most important criteria that we look at. So I take 25 as a median. So anything below 25, it's better to avoid, because these are the cases that are more likely to progress or be more unpredictable. But above 25, as they go nearer 30 and all, these are the cases that are more likely to be stable. And in these cases, you can try for a refractive surgery, either a topo-guided surface ablation or a phakic IOL. And the third common scenario where you pick this irregular astigmatism is just before your cataract surgery. So when you have surface issues like SND and pterygium, ideally you have to correct these issues. SND either with a superficial keratectomy or a PTK, and remove the pterygium, give the cornea at least 6 to 8 weeks of time, let it stabilize, then take your topography readings and biometry readings and go ahead and do your surgery. And if the irregular astigmatism is because of ectasia or any other causes apart from these correctable causes, I don't think toric IOLs is a good option in these cases, because once the toric IOL is planted, the patient expectation goes up. So however the patient is happy prior using glasses, I would recommend the same by putting in a monofocal lenses in these cases. Some of the surgeons may prefer to use a toric IOL, but I personally would not advise for a toric IOL, because the outcomes are suboptimal, but the expectations are one when the patient pays more for a toric IOL. And surface correction in these cases can be better, but if the patient is already using, because in cataract means he has already been using some form of vision correction, most likely to be glasses, or if he's already using contact lens, there is no harm in continuing the same after cataract surgery. And some special situations are scars, post-trauma, or post-PKP. And in this also, the previous speakers have highlighted well the role of pinhole pupilloplasty. And just to add a few points on surface remodeling, Keir's Bowman's layer transplantation, these also have a role in the surface remodeling. Once the surface remodeling is there, then you can combine it or do it alone in pinhole pupilloplasty to increase the visual outcomes. And special contact lenses are the most important part in treating all these cases. And the RGP trial in all these cases will give you a very, very good impression on how these patients are going to have their outcomes. So most of the times you see a very dense scar, but when you put the special lenses on, most of them improve to 6966. So in these cases, we need not touch them at all. They're happy with the lenses. And these lenses now, thanks to LVP and a lot of Indian manufacturers, now we are able to get lenses for a more economical price. So once we start using these special lenses, the indications for more rigorous procedures like keratoplasties will definitely come down. And only the situation where I avoid the special contact lenses are one-eyed patients, where the risk of infection is also there, and they may not be happy with the quality, or the brain may not accept the binocularity is there when compared to both eyes. So in one-eyed patients, I try to avoid this special contact lenses, but otherwise in all the regular cases, my first choice is to try this contact lenses, whether scleral, mini scleral, or so many options, whichever is available and comfortable with you. So the take home is, it's very important to know about this irregular astigmatism, especially before surgery, because it has a direct impact on the visual outcomes. Analyze the cause and see whether it is stable or progressive. First, stabilize. Early detection and stabilization is the key. Vision improvement, definitely specialty contact lens has a key role. Avoid LASIK in these cases. Go for topo-guided PRK or surface ablation in selective cases. Toric IOLs also I would avoid. If the patient is very keen for refractive surgery, maybe phakic IOLs also may be an option, but in selective cases. So highly irregular corneas and special situations, I think even pinhole pupilloplasty has a role to play. Thank you for your time and attention.
Thank you so much, sir. That was like the three most common scenarios, and you put it very clearly how we are going to triage. I'd like to invite Dr. Meena ma'am for her comments. Ma'am, I would like to ask, we regularly see in tier 2, tier 3 city where when the patient is diagnosed with such conditions, which is progressive, we tell them intervention and they take some time to decide it. It might be 3 months, 6 months because they are going to multiple settings. And due to the progression, then the case sometimes the unfavorable outcome comes into picture. So what should be the immediate intervention that we should do to triage such patient before the patient is like moving to other centers?
You're asking me in terms of keratoconus or because
Yeah, mostly keratoconus because other
because,
like scar and everything it's more stable.
Yeah. So one thing is I do get to see a lot of patients from other cities who come to our center. I think it's best not to scare the patient. One of the reasons why patients shift centers is they have a fear that their cornea is going to get thinned and it's going to burst and they're going to go blind. So you need to educate the patient about not itching, about using drops first, about the good part about keratoconus is when detected early, there are contact lenses, there is cross-linking, and once these early interventions are done in time, your life is going to be much simpler. You're going to lead a normal life. The only problem comes is when these are not told and the worst outcome is told to the patient, like, it's going to become very thin, you will need a keratoplasty. That's when I think patients get very confused and want to know multiple other options from many others. And in that way, we tend to see a lot of investigations being done in different tomographies and topographies and all that. So when it is close to a pachymetry close to 400, I think it is wise enough to put it very gently to the patient that cross-linking is not going to reverse your keratoconus, but it's going to stabilize your keratoconus. And in the future options of using a contact lens or even glasses is very good, and your child can continue to have a normal life. So this is something which I am only able to think offhand right now. And does that answer your question?
Yeah, I think, ma'am, that does, because we generally in tier 2, tier 3 city, we like get panicked. The doctor get panicked ourselves and try to over counsel the patient
Yes,
about
and yes, I think you have to give the patient that the disease is a slowly progressive disease. Okay, so that is a very important thing for the patient to keep coming back to you. So we do not want to see patients from very small cities traveling 2,000 kilometers. No, we don't want to do that. I'm very sure that everybody now, there are a lot of practitioners. So, and you have to tell them that these scans are not to be repeated very often. It's very scary. Always, when you do a scan, tell the patient that this scan will be repeated only after 4 months for comparison and not every month or thing. A patient loves scans for some reason. They just go by the scans. So, but you have to tell the patient that we are asking you if your quality of vision is changing, your retinoscopy cylinder is changing. So I always tell the patient, your vision is stable, your cylinder is stable. Unless you tell me your quality of vision is changed, I am not going to do the test. I'm not going to do the test just because you're asking me to do the test. You need to answer me if you're stopped itching, if you have still allergies. Only then I'm going to do the testing for you. So, and if the patient has crossed a certain age as 30s and all that, I do not want to do the test just because they want it, unless they have a grossly changed vision. So I'm just being very practical.
Yeah,
I'm not sure.
Thank
if
you,
that.
ma'am. Actually, that is a very yeah, ma'am.
One question to you, Meena. Do you also get patients who are who have over searched the Google and who are already stable keratoconus who want to go for cross-linking, which is I think.
most of them want to know C3R because that's written in their prescription, in the top of their prescription, C3R. So I'm very sure, yes, that because if you are in a smaller city, if you don't tell your patient that this option is not there, it doesn't look good also. But then the patient for some reason misinterprets that and reads the Google and says that this has to be done. And for some reason, they believe that if it is done in a bigger center, it is always better. So I always tell them that the procedure is a very standardized procedure, and wherever done, it is going to be the same. So I strongly recommend them, because of follow-up, to go back, if possible, to their own doctors. And some of them have educated me. For example, they've been some of them have told me about implants also. So yeah, it's Google is not all that bad. Yes, it can be annoying at times, but yes, yeah, the gentle gentle talk does wonders, I feel.
Thank you, ma'am. I'd like to just move on to
Nilesh,
the next question.
excuse me.
Yes, sir, please.
Can I add something?
Yes, sir, please.
Okay, ma'am. You please.
I can
Anamika,
ask?
ma'am, please. Yeah, please, ma'am.
I wanted to know about very rightly said that theory IRs are no. But how about EDOF? Like, what does the panel think about putting EDOF in such patients? EDOF lenses.
Yeah, I would I was going to ask on similar line. There are two things. If you are going to get a patient with pterygium and cataract, most of the patient they want to get it read in the same sitting. But we like tell everybody says that it has to be like in two sittings. But what is the minimum waiting time? And then if there is a then there is a question. First, the pterygium is done. We wait for some time, and then should we go for EDOF or monofocal if we are waiting and doing the pterygium first? So, Madhu sir, Jinupriya ma'am, please.
As far as pterygium is concerned, I'll first look at the age of the patient, and that if it is just a atrophied pterygium, it's not affecting the cylinder, I may just let it be. And but if it is affecting the cylinder and the cylinder is high, I'll counsel the patient that first we'll do this pterygium surgery, and after 1.5 months, after the biometry and K readings are stabilized, then only it's better to do the IL surgery, because I'll explain him about the IL power and everything. So that's my routine. And I'll also do the surface stabilization with that. About multifocal, your question is about multifocal,
Not
EDOF and multifocal
EDOF
lens.
advanced monofocals that are coming, and EDOFs mostly.
So that again will depend on how the surface is. After the pterygium surgery, we'll get the topography done, and if it allows, then we can explain the patient. But if there is scarring, then I'll prefer not to go about the multifocal lenses.
Yeah.
And what will be your time, sir? Waiting time?
I think
1.5 months. Usually the K readings stabilize over the period of 3 months, but we take the midline, and usually for all practical reasons, we
6 to 8 weeks.
We get the IL surgery done at 6 to 8 weeks.
Yeah. And I think the IOL choice for me still would be a monofocal. Next would be an enhanced monofocal, where you don't see that visible ring like the Vivinex or whatever you want.
Yeah.
And the EDOF with the proper EDOF like Vivity and all, I would still avoid, because the same reason I have told you, the cost increases, your expectation of the patient goes up. So the first choice would only be a pure monofocal. Yeah.
Perfect. John sir, you were asking something.
Yeah. Can I ask? Yeah. With due respect to Meena ma'am, she was my fellowship mentor. So I think one thing I want to differ, because we have seen couple of patients, even also recently I've encountered the postgraduate training, who during whole MBBS, they went to their own ophthalmic department, but the case keratoconus was undiagnosed. And recently she came to us to last year. That time the one I having the 311 thinnest packy, other eye 410. So every time she went to their own college, and there sometime it was underdiagnosed. So in this scenario, I think, and those even some patients, those who come from the periphery, even they say they are pretty, regular from the compliance from their side. They say we regularly visit every 6 months, 1 month. I had a history of the frequently changing glasses. Whenever retrospectively asked the patient had a history of the vacancy symptom, and they are not, I mean, poor compliance for the glasses. In this scenario, I think the diagnosis is, I mean, the better than the undiagnosed thing. And you should not be very particular that we should not be do the, that investigating. If you have a doubt, and these three things should be matched. If you had a history of the patient, like young adult patient, history of the vacancy with a high cylinder, and the patient frequently change the glass power. So in this scenario, I think is it a common platform for the all the ophthalmologists under the AIOS banner. So if you have a doubt, simply if you may not have the or your OBSCAN or maybe the pentatopo or tomography facilities, simply do the retinoscopy. Ask your optometrist or your cell phone that what you will use to learn. We do the retinoscopy. You have even all the high cylinder patient, in spite of the your pentacam or OBSCAN, whatever we have. We routinely do the after what are the test, we do the routinely OBSCAN and do the scissoring is there or not. If you have a doubt, send some of the higher center where it can be clarified whether the patient having the case is there or not. Even the patient is under the first group. If it is so, then you regularly follow up the things. In this scenario, I think I'm little proactive. Well, it's not that we're doing the test for every month, but sometimes we are actually undiagnosed. When they came to us, then it's very that I'm then really I mean this girl who is doing the MD psychiatrist third year and now the DNB and now she having this 311 and the thinnest packing. And now she's using the your RGP lenses. I'm not Adara having the 6:9 vision with the spectacle correction. So in this scenario, I think it's better to give a, I mean we should be aware our colleague, those who are in peripheral part, they should be little proactive.
That's right, Dr.
Thank you,
John.
sir.
I think these are certain challenging cases each one of us faces, and this is how we learn and we also grow together. So moving on now, I have the pleasure of inviting Dr. Manik Nicholson to present on advanced imaging techniques in irregular astigmatism. So Dr. Nicholson, the stage is yours now.
Yeah, thank you so much. Is my screen visible?
Yes.
Yeah.
So good evening, everyone. Thank you so much, Dr. Nilesh, Dr. Purvasha, and the entire AIOS Scientific Committee. It's really an honor to be a part of this group, this erudite group, and to be speaking today on this topic which was given to me, which is advanced diagnostics in irregular corneal astigmatism. So Dr. John has already very beautifully described the causes of irregular astigmatism. I just found this classification, which I thought I would put in. They're broadly classified into those cases which are associated with thinning and non-thinning. Thinning causes include non-inflammatory conditions like what we've just been discussing, keratoconus, iatrogenic factors like post-elastic ectasia, and inflammatory and infectious diseases. Non-thinning causes include deposits, like was mentioned earlier, dystrophies, mechanical factors like contact lens warpage, and traumatic and iatrogenic injuries. Now, the placidose disc was one of the earliest methods to image the anterior surface of the cornea. In contrast, machines like the OBSCAN and the OPD3 scan combine slit scanning and placidose disc technology to measure both the anterior and posterior surface of the cornea. So, however, now we have a lot of new modern topographers like the Pentacam, Galilei, and Sirius at our disposal, which utilize technologies which combine Scheimpflug imaging with placidose and other imaging technologies in order to image both the anterior and posterior surface of the cornea. And so we will be discussing the role of some of these imaging modalities under these 6 headings, and I'll take you through them one by one. So the first was to screen for corneal ectasia, which has already been touched on earlier. Topographers like the Pentacam here provide detailed corneal topography, which includes corneal steepening, posterior elevation, and thinning, which are all hallmarks of keratoconus. And the OCT, in addition, provides this pachymetry map, which, in addition to providing pachymetry, also gives you the epithelial thickness. And this I find very critical because any changes in the epithelium, such as compensatory thickening or thinning over the cone, help both in diagnosis as well as in monitoring progression. So topography also plays a crucial role in differentiating keratoconus from PMCD, which is pellucid marginal corneal degeneration, and the distinct pattern of corneal thinning in keratoconus and inferior peripheral thinning with the typical crab claw appearance, which is seen in PMCD, are easy to distinguish on topography. The OCT also helps us in documenting this peripheral thinning, which is seen with PMCD. In some cases, these conditions may overlap, which makes it difficult to differentiate them solely on the basis of topography. This is another degeneration called Terrien's degeneration, which is a rare non-inflammatory progressive thinning of the peripheral cornea, usually limited to the supero-supero-nasal regions. It is characterized by a localized thinning, and unlike keratoconus, there's no central cone. The overall pattern is a lot more eccentric, and the OCT over here typically shows stromal thinning, especially in the areas of superior nasal steepness. So this map looks highly irregular, and I just put it in over here to show that it is necessary to correlate with the clinical picture, because sometimes it might just be as easy as a corneal scar, and therefore sometimes, as Dr. Karishma said, the map comes to us and we might not have correlated it clinically, and therefore the topography here in these kind of conditions helps us in planning for future treatments, depending on if we have an OCT at our disposal, the depth of the scar as well as its location will help us in planning either a laser or a surgical treatment for such conditions. So screening for corneal ectasia in my mind is divided into 5 headings: topography, tomography. You can combine it with aberrometry for diagnostic confirmation. You can combine it with biomechanics for classification. You can use OCTs as well for staging and grading. And for prognostication, all these 5 help. So we'll go on to the next, which is monitoring and treatment. Once corneal ectasia is established, say it is keratoconus or PMCD, topography helps us to monitor disease progression and identify those cases which require treatment. This one here you can see clearly shows progression, while the one to the right does not. At times, tomography and OCT are superior for assessing corneal thickness as well, as against ultrasound pachymetry, which was mentioned by the speakers earlier. And in advanced cases of keratoconus, OCT is particularly helpful because it helps us in our surgical planning, especially if an invasive procedure such as a DALC or a PK is being planned. In planning for intact, topography is very helpful, especially the pentacam, because firstly, it helps us to differentiate whether the cone is centered or decentered. And the OCT per se helps us post-intact. So monitoring corneal changes helps us to ascertain the position of that ring, and also if there are any epithelial irregularities or whether there are any shifts in the position of the ring. The data also helps us in planning these segments and in placement of the location of these segments in our incisions in order to best reshape the cornea in order to get the best fit of these rings. Topography, as we all know, is essential in refractive surgery screening, and this is the mainstay of where we use topography in our clinics. It also helps in refractive surgery planning in picking up these early red flags, such as in this case where you'll see that there is some amount of thinning, and where topography might sometimes fail us. Something called biomechanical assessment using the Corvus ST is very useful. The Corvus is valuable in refractive surgery, especially in these red flag borderline cases, in order to identify corneal elasticity and strength of the cornea, especially to identify those which are at risk of ectasia. Now, the Corvus has many parameters, out of which the CBI, which is the corneal biomechanical index, focuses on pure biomechanics, while the TBI, which is the tomographic biomechanical index, combines tomography along with biomechanical data to give you more accurate early ectasia detection, ensuring that your patient selection for refractive surgery is safer. Topography is also valuable in irregular astigmatism patients, as elucidated by the earlier speakers, especially when you're planning these kind of cases, which we were just discussing, toric and non-toric lenses. You can see that this was a patient of post-LASIK ectasia. This, I might add, is a particularly demanding subset of patients which do expect that they have been spectacle-free for very long and now come to you for cataract surgery with very high expectations. So in such patients, especially in patients who have very large variability in K readings, as shown by this EKR report on pentacam planning, as Dr. Madhu mentioned, a monofocal lens might be the best option. In post-LASIK ectasia patients with decentered scans, the problem might be at the corneal level, but additional aberrometry tests such as the eye trace complement this by confirming whether your decrease in vision and the symptoms of the patient are primarily because of the cornea or because of additional internal optical issues caused by early cataracts, which might be contributing to their symptoms. The fourth point, preoperative IL selection is also important in patients who have had RK surgery, as was mentioned here. This was a patient who presented post-RK, and when we did his OCT, we found that he had significant subepithelial corneal haze as well. He had 8 RK cuts, and because of this wide variation in the keratometry readings, again on the EKR report, we decided to go in for a monofocal IOL while also prognosticating him about suboptimal visual outcomes because of his scar. The fifth point was post-keratoplasty astigmatism management. Now, patients who've had a PK or a DALC surgery done do tend to develop significant ciliary because of tight sutures. And a targeted approach to removing sutures allows us to flatten that steep meridian and help reduce astigmatism. Topography, as mentioned by the speakers earlier, also helps us to document a reduction in cylinder post-pterygium surgery. This was a patient whose 10 diopter cylinder reduced to almost 0.8 diopters after removal of this, I would not say a very invasive pterygium, and you can see that cataract surgery can be planned better in such patients. Corneal warpage is also often seen after prolonged improper lens use, and topography helps us because serial topography helps us show that these are transient changes, and with discontinuation of the contact lens and treatment of the ocular surface, these changes can be reversed. So, and last of not the least, of course, a very simple diagnostic test is, of course, in a very resource-limited setting, as was being discussed by the speakers earlier, is just to do an RGP trial. And if the vision improves, it suggests that the presence of irregular astigmatism can be corrected by this RGP lens and also serves as a diagnostic test. Thank you so much.
Yeah, that was a great presentation, Dr. Manik, and with advanced insights into how to image these patients. So over to you, Dr. Karishma. We would like to ask you, with all these advanced imaging techniques that are available, which help you to go in for an early detection, and what is your take on the epithelial maps?
So I think my personal choice, without having any financial interest, would be the Pentacam for early detection. I think that is majorly because we have maximum data on the Pentacam because of the sheer fact that it's been around for so much time. What we need to realize is that Pentacam would be, a Pentacam or a Cirrus, basically a Scheimpflug imaging, would be very important when we are looking at refractive screening to look for those early changes. But for example, if you're looking at a basic topographic change from a pterygium, there you don't necessarily need a Pentacam. You can get away with a regular Placido imaging by itself. So it's important to realize that Pentacam has its own space. And I think it is undebatable in refractive surgery. But there is a basic Placido to help you with most things. And nowadays, even your Placido topographers come with some sort of algorithms which can help you have your keratoconus screening because of the criteria that it comes with. So that's part number one. Part number two is about the epithelial mapping, which cannot be overlooked. So when you are looking at early changes, and if you don't have a Pentacam, it would definitely matter if you did have an epithelial mapping, because that will help you then to pick up those early changes which you may not otherwise, which you may otherwise miss if you don't have the Pentacam.
That's right. Right. So,
Urvasha, can I just say something?
Yeah, please go ahead.
Yeah, so it's regarding the use of advanced lenses after pterygium. I've had my own share of experience of removing pterygium and having a smooth polish. It's like when the Bowman's is not very disturbed, and when you see that the topography or this four quad map shows a very smooth K readings, and the Pakis are very thing. I have actually used trifocal lenses. So it's not that always we have to avoid using lenses, but once the surface is very regular, I think we need not shy away from using trifocal lenses, although you would need to counsel the patient. So
thank you, Dr. Neeta, for sharing your valuable experience with us. And I think it's all tailor-made, and each
it's not as bad.
Yes, it's all about giving a choice to your patients for each eye. Even in the same patient, the two eyes might be behaving different.
And also, to answer John's question about doing investigations, like I think he misunderstood when I said doing investigations. So the question was on already diagnosed patients of keratoconus. So when you already have the patients diagnosed with keratoconus and you know what to do, then I wanted to reiterate that, do not overdo, do not scare the patients, and, do the C3R when it is 400 microns. It's not for those patients who go undetected because the general ophthalmologist himself is unaware about the irregular astigmatism. Yeah.
I agree with
Yeah.
ma'am. No,
Yeah.
what I'm telling, along with that, sometimes what happened, we saw the patient, they're very much, I mean, advanced cases, but general ophthalmologist, maybe they are very reluctant to
Yeah,
refer
this
the
is not
patient.
for general ophthalmologists. I was talking about cornea specialists in tier 2 and
That's a
tier
very,
3
that's
cities.
100% agree with ma'am. We never usually inculcate the patient to do the, I mean, you every monthly or twice. Definitely until unless 4 or 6 months, we can't be appreciate the whether any changes is there or not.
That's right.
100% agree with ma'am.
Right. So, due to certain unforeseen situations, I think Dr. Bhaskar has not been able to be with us, and he was
Sir
supposed
is having a high fever, so that's why.
So, we have his, he would have discussed pediatric considerations in irregular astigmatism. And I think Dr. Madhu has already covered quite a lot of it in his management slides. We would like to know from Dr. Vinay sir, if he's around, what are his practical points while dealing with pediatric patients, and especially taking care that these are in the amblyopia age group. So how do you manage them, sir?
Well, it depends on, what is causing the irregular astigmatism. Basically, we have to make the patient see well and as early as possible. So, depending on, the most simple thing is to use glasses if that works well. Okay, surgical intervention in this age group is a little dicey in terms of, what is going to be the effect in the long run. Again, yeah, managing the root cause. If it is keratoconus, yes, you have to stabilize it. I mean, if it is something else like a, lid margin problem or allergy, you have to treat it, control it, and then address irregular astigmatism rather than, jumping to manage that at the first go. Yeah.
Yeah.
I had one question.
Can I just add one point to this?
Can I ask the
Yeah.
question?
Please go ahead, Dr. Ashi.
So my question was that I sometimes get children with keratoconus with already existing amblyopia, and they go for amblyopia therapy, and patching becomes should patching be a concern, because that might be rubbing against the eye, and so should we I have been asking my pediatric ophthalmologist to go for something else like atropine or a cupped this thing instead of an occluder.
I really don't think so, because there is a huge difference between rubbing and patching, right? You are not rubbing, repeated, high pressure, something on the surface which is causing the whole microtrauma, the cascade which is believed to cause the progression or whatever it is. But then at the same time, you're patching, it's a short-term period. And nowadays, I don't think they do patch for a day or things like
No,
that.
it's only 6 hours usually.
Yeah, 4 to 6 hours, depending upon the age group and the density. I mean, how deep the amblyopia is. I really don't think that really affects. It's just my opinion. I don't have any evidence to say that it does or it does not. But then, no, I don't obstruct or tell them not to do that.
Dr. Anamika, you were saying something.
Yeah, actually, I agree. First thing is in context to the previous question of Madam, keep patching. 2 hours also has an equal effect. There are a lot of studies which say. So what sir was saying is right. Nowadays, we don't patch for a day or so. 6 hours, 4 hours, or 2 hours also show equally effective results. My question to the panel was that since the topic is on pediatric keratoconus, lot of these patients have BKC, and due to rubbing they get keratoconus. So suppose if we get a patient, obviously we have to treat the inflammation first. We have to tackle that first. So now such a patient comes with a thin packing and the inflammation is there. We are treating the inflammation. Will a low threshold would be there for considering these patients for C3R? What would be the take? What would be the take?
The
You
primary,
treat this patient inflammation
In
and
same-
they have a package. So would you consider them little early? Means
I don't advise doing a procedure before we get the, the basic problem under control, the inflammation, allergy, or whatever it is.
correct.
I think in terms of C3R in these cases, they have a, high, or compared to a person who doesn't have allergy, the possibility of getting a haze or even scar post C3R is quite high in these cases. So the the first step will be to control the allergy and inflammation. And
So
then
the allergy.
once that is controlled, yes, the threshold for doing C3R is quite low in these kids.
Yes,
So
ma'am.
suppose
So we've been seeing that a lot of thinning is occurring once they
Yeah,
have this
yeah.
inflammation. And it's also
Yes.
very important to tell the patient to continue anti-allergic medication after the C3R also. So either way that would otherwise it would be you just not help the patient if you don't tell the patient not to rub and not give anti-allergy medications.
I would like to take the discussion to the other age spectrum. Apart, like in the old age when MGD is happening and we are like telling the patient to do warm compress a lot and then do lid massage. There are theories that are coming up that the warmth will loosen up the collagen, and if when we are doing regular lid massaging twice a day, it might again restart or induce a new astigmatism or irregular astigmatism. Any expert comments on that? Is it a possibility, because that is being theoretized a lot? There are lid squeezers that are coming just because with the comment that if you just do like lid massaging, then it will affect the globe. So just do a lid squeeze, like take it away like a forceps and then do a lid squeeze.
Difficult to do it.
I would be happy if my patient does warm compress and lid massage.
These are dangerous sounding gadgets.
I'd like to add something regarding Dr. Anamika, what you mentioned about the thin pachymetry. The group from Narayan Netralaya has introduced an online calculator, which I believe is now open to access for all, in which even if you have a thinner pachymetry, you can feed in the pachymetry of the patient and it will tell you the modified protocol. So it's called the modified protocol for thin corneas, where even if your patient has a thinner than 400 pachymetry, it will tell you how many less minutes that you have to do for that, or how many minutes that you have to do for that particular patient, and that protocol is available only available online as online cross-linking calculator, if I'm not mistaken.
Thank you, ma'am. That is a nice segue actually. That our next topic in panel discussion was a use of AI in the diagnostics and the management of keratoconus, and Narayan
Just
Netralaya,
1
I think,
minute.
has been yeah ma'am.
So because Bhaskar was not there, I thought I'll pitch in one particular aspect. Many of you must be seeing dermoids with irregular astigmatism. So one of the false conception is operating a dermoid actually reverses the astigmatism and actually improves vision. So I just want to reiterate here that the astigmatism with dermoid is almost permanent, and doing dermoid surgery is only for cosmetic reasons. So I just thought I'll share this since Bhaskar was not there. I'm sure he would have said this if he was there. Yeah.
Thank you, ma'am.
Dr.
So,
Nilesh, can I ask a question?
Yeah, ma'am, please.
My question is to Meena Madam. Pediatric cases with keratoconus. Madam, what is your experience? Have you seen progression even after doing C3R? How often do you encounter?
See, the study that we have published at our group in 2015 showed that the Kmax actually stabilizes by 3 months, and then the pachymetry drops down in another 6 months and again raises. Now, this is because new collagen tends to come back in the cornea. So if there is all a new production of collagen continues, so whether it is whether it is the collagen or whether it is the keratoconus progression is very difficult to say. And I'm the worst people to get back this progression are those people who are rubbing their eyes. But as such, no we are seeing thinning. I think we have right now taken a step back and stopped doing C3R at the first stage, and we are trying to get the patient's inflammation under control before we do C3R.
Vinay sir, ma'am, we need to move ahead with the panel discussion otherwise because we are short of time. So, sir, Vinay sir, how much do you see in the coming decade that the individualized protocol, AI-based protocol, is going to dictate the C3R protocol? You and also Somshila ma'am has joined. Welcome, ma'am. Her comments as well after you.
Yeah. Personally speaking, I don't have any experience with the AI in these things, but then quite an interesting field, upcoming field. I think that is what the future is. Okay, finally, the whole treatment is going to be individualized, whatever be the disease.
Somshila ma'am?
Yeah, so at LVPI, we also recently published, Rashmi had published a large set of patients with keratoconus and looked at what happens to them, pediatric patients, and then adult patients was a large cohort. And that's what the AI modeling also would look at. So if these large data sets can be entered into some kind of machine learning, then we might have some predictability. But at this point, I think it's too sort of incipient to say how AI will help us, because we see a lot of variables. For example, what we see in India is very different from what they may see overseas. Even rural to urban, we see differences. So it's really hard to predict.
Right. There is possibly also a variation between institutional practice and individual practices. And I think AI is yet to go a long way where we can actually institute all these things uniformly for all patients.
I think AI still has a role right now as diagnostic modality. They are helping to like read the topography map and give some kind of indices. But
They're also
more than that,
integrating the biomechanics along with the tomography.
along with the in the Corvus. So probably we need to look at that back, say in around 2-3 years, to know more about how this is going to affect us, our practice. So the next question,
Nilesh,
Dr.
can I
Purvasha,
have a
if you can.
quickly question to panel?
Yes, sir, please.
Yeah, just to all of the panel, my this query is that suppose we are planning for a cataract surgery in a post-PK or DALC patient, and we have a significant amount, suppose more than 6 or 7 cylinder. So what the formulation you plan, and do you prefer the toric lens?
Dr. Somashila, would you like to take this question?
Yeah, thanks, Purvasha. So, very simply answered, John, good, excellent question. And the main thing that you have to make sure is that the sutures are out. And this is not a progressive kind of an astigmatism. When I say progressive, you know that when you do DALC for keratoconus, you can have recurrence of keratoconus, especially in the inferior area and so on. So if you're at your final stop, final destination, all sutures out, and even if the astigmatism is not very irregular on topo, so you can consider a toric lens. We have done, many of us have done that with fairly good results. But otherwise, stop, then you're better off using a sort of an aspheric monofocal lens to get a good result and see how you can address the astigmatism. You can do TRK, or you can do incisions or something like that to address the remaining residual astigmatism.
Yes, thank you for your insights, Dr. Somashila. And
Thank
we'd
you, ma'am.
like to move to the last question. This would involve the patient expectations and the financial considerations. So your insights, Dr. Vinay, on this particular aspect.
Financial considerations, both the patient and to the doctor is the doctor or the institutes. I mean, a lot of, things which we need to do in these cases with irregular astigmatism are, dependent on a lot of gadgets which are not easy to come by. Okay, it might be quite easy when you're in an institute where you have, multiple things available. But then when you're in a place where the resources are quite limited, you have to think within that and then decide how to proceed.
Dr. Jinupriya, would you like to mention something about the patient financial expectations? You're on mute, ma'am.
So it has to be like customized and decided according to the severity of the disease, according to the stage of the disease and the financial status of the patient. If the patient is not like having, if it's a kid, if it's a small child and he needs C3R, patient is not able to afford, we can refer them to some institute. But we have to counsel them that this is a progressive disease which progresses mostly in the age of 10 to 40 years, and we that like pubertal age, it's very aggressive. So we have to counsel the patient, and then we have to leave something for the patient to decide. We have to give them all the options. We have to explain them about the disease severity, about the seriousness of the disease, and then we have to give them all the financial options available at our center and at other centers. So whatever is the best, the patient can decide whatever is best for them.
That's true. So all the options are to be mentioned. Sometimes seemingly non-affording patients also manage certain funds, and they can also get rehabilitated in the best possible way.
So one thing where every patient, like we all face a lot of resistance, is for the scleral lenses, which are the best treatment in irregular corneas. And I think one of the best investments that the patient can make. So that needs to be pushed across to the community.
Thank you so much, ma'am. I think we had a very great discussion, and I would just like to ask the concluding remarks from three of our panel and chairperson, Dr. Anamika ma'am, Dr. Vinay sir, and Dr. Meena ma'am. These three are like, how do you explain your patient to manage their like visual expectation and what the condition is? So like a take home away message if the patient is having say a progressive disease in keratoconus, or something that is going to progress, and they are having high expectation of high expectation of visual outcome, and that will be a take home away for a message for all the general ophthalmologists. So please, ma'am. So
Dr. Anamika?
Meena ma'am, please.
Yeah. So if you're going to talk about progressive disease, and I have controlled the allergy factor, talking about the cross-linking is an important thing that you would tell. You would tell them that it's an outpatient procedure in which the patient has to comply to lying down for certain time, and when there is going to be some amount of overnight discomfort, and then they're going to be fine in a few days. And also tell them that it takes a week for them to go back to their natural work experience. And talking to them about their medication is very, very important. And about their high expectations, I try to do a contact lens trial prior I do the C3R, because I want them to feel how it is, how nice it is to see very clearly. And this itself is it helps them to actually go ahead for the procedure and know what a contact lens. If you're trying to introduce a contact lens after the C3R, sometimes you're not very successful. But if you have had a trial of a contact lens before you do the C3R, then you probably have won a little bit of the patient's confidence in trying to adapt to the contact lens. My go-through visual rehabilitation has been contact lenses for most of the time. I have very little experience of doing ICL simply because I am still not very sure about their outcomes and the procedure of doing the ICLs in these particular patients. So I would tell them to invest their time and money in Boston in scleral lenses, and tell them that since these lenses are not very frequently changed, like they're changed once in 4 years, and this is the best thing that they can do for their eyes. And most of them have this very myth that if they're an IT professional and if they're going to see the computer, their keratoconus will increase. So I tell them that you are probably in the safest thing, not going out and rubbing your eyes because of dust. And so you are actually very lucky that you are doing this and you have a contact lens to help you. So I think that's it that I have to say. Yeah.
Vinay sir. Sir, you are on mute, sir. Vinay.
Yeah, in people with documented progressive keratoconus, well, I tell them, our treatment is basically for two things. One is to make sure that things stays at what level it is, and the second thing is to make you see well. Okay, and one treatment is not for the other. Okay, stabilize, you will have to undergo cross-linking. For vision, one of the refractive, treatment options like glasses, contact lens, whatever will give you good vision, that has to be used. And this is what I tell the patient. And as Dr. Meena said, it's the contact lens before C3R is very good, point which she has brought out, because it's just not to make sure that make the patient see that it will help in improving his vision, but also in, making us understand what is the visual potential of the patient. Is it worth doing a cross-linking there in that case? Okay. A patient who has very poor vision with spectacle correction, but has good vision with contacts, but is not tolerating contact lenses, then is there a point in doing cross-linking there? Okay, that kind of differentiation, is important, because in that cases we have to think about other treatment options like a transplant or something.
Thank you, sir. Anamika, ma'am, any concluding remarks for today's
Most
webinar?
of things they have covered. However, spending a good chair time with especially in cases of a pediatric patient, with their parent and explaining them the importance of treating the inflammation would be a very good idea. Also, stressing upon a good follow-up, a regular follow-up would be required. Having C3R doesn't mean that the treatment has stopped and they are cured. So, regular follow-up is important, and also explaining them to keep a realistic expectation would be a very crucial thing in the treatment, especially in treatment.
Thank you, ma'am. Last remark from Somsila, ma'am, if she is
Uh,
available.
yeah, I have a slightly different philosophy now, and this has evolved over years, Nilesh. As you know, that now we have so many other options available. So I'm going to talk about the adult patient with keratoconus, and let's say you said progressive. So let's say that it is progressing, and now the patient has several options, which is mentioned earlier. Earlier, former days, we used to always push them towards contact lenses, RGP, and then scleral lenses. Think about it. Can a young patient forever and ever use these contact lenses? And so to me, contact lenses is an option, but it's not a solution. So what I'd say differently for adult patients, see if they are going to use a contact lens, exactly like Meena said. If they're motivated for contact lens, that's of course, the best case scenario, and do the cross-linking and then they go back to contact lenses. And I rigorously try to screen and see if I can use ICLs for them, if I can use intracorneal ring segments for them. And there's several other variation on techniques of intracorneal ring segments. We also have sort of a Bowman membrane transplant or epithelial layer with Bowman's membrane transplant, which Vikas Mittal and others have shown good results with those techniques. So I would really exhaust all these options and try to see if I can align my patient towards one of these. This is for the adult patient without allergy being one of the major concerns. For pediatric patients, there's not much choice. Control of allergy, severe allergy, and then probably try and see if you can get them into contact lenses. That's a little limited. Of course, cross-linking is the savior over there. That's my current philosophy.
So
Thank you, ma'am.
Somashila, Dr. Somashila, you feel that stromal inlay CTAX will probably be the future of
No,
rehabilitation?
That's coming up. I have never used one of them, but the only inlays I've used are the intracorneal ring segments, and I've had good results with them. This is for the adult patients, of course, but for pediatric patients, as I said, there are very few choices.
So one information has come on YouTube also, that Dr. Yash Kala has said that a sub 400 CXL protocol by Dr. Farhad Hafizi, is there, which customizes which gives customization and all protocols that are available. So thank you, Dr. Yash, for that information. And with that, I would like to conclude the webinar. I am very grateful for all the chairperson and panelists and speakers. This has been a really wonderful discussion, and I think a very useful one for general ophthalmologists. And I would like to thank AIOS, especially Dr. Santosh Honavar sir, for providing me this opportunity and me and Dr. Purvasha to conduct the session. Thank you, team from Numerotech, to support this webinar. And with this, I wish good night to everyone and hope to see everyone in the next walk-in webinar next month. Thank you, everyone. Good night.
Good night. Thank you. Thank you,
Bye.
everyone.
Thank you so much. Good
Thank
night.
you.
Good night. Good night, ma'am. Bye.
Thank you.
We can stop live streaming.